what we did last week? Yes. A summary of what we did last week. Hello? Hello?
Hi, sister.
Hi.
Yes, please, I'm
Hi.
waiting. Okay, so Elizabeth, take us through what we did last week in just 1 minute or 30 seconds. Okay. Georgina.
Yes, sister. Please, last week we spoke about clinical decision making. And then we said it is a continuous information we gather to take care of our clients or to that is the information we gather, which include history taking and all of that. When a client comes into labor, we take into consideration listening to clients, looking at clients, touching, and then doing some examinations to gather information and then to continue care for clients and also to plan care. And then we spoke about some terms we use sometimes interchangeably. That's pueriperium, line-in, postnatal, and then we spoke about room, and then the other one, it escaped me small. So that's a little I can say about.
Okay, thank you very much.
You're welcome.
Thank you. All right. So last week, did we? I don't know. Oh, it's not this class. I asked somebody that when we come today, we will talk about it. Maybe it's not your class. Okay, so like he said last week, we talk about the clinical decision making. And then we were in college, we were given an assignment on the clinical decision making. And then we were asked to use the assignment, pick clients from either the antenatal clinic, the labor ward, the PNC, or the postnatal ward, or the lie-in, wherever you find yourself. We're supposed to pick a client and then use the clinical decision-making steps to manage the client. So when we were looking at the steps, we talk about all the 6 steps in the clinical decision-making. And then from there, we look at the common terms that we use in our facility, and then we differentiate between them. And then we quickly the labor ward. But we said because of space issue, it may be that you'll not be able to get the normal setup. Then from there, we started defining some of the terms, and then we look at definitions and the principles and the stages of pueriperium, and then we talk about bonding and rooming in, and bedding in, sleeping in the same room with the baby. We discuss how we can bond with the baby, the parents bonding with the baby. And I said we should include the father because the father too is part of the process of bonding. So whatever we do, we should include the father in the management of the clients and then the baby. Then we look at way in which we can build them up the confidence of a mother. And I remember I gave a scenario that this 30 years or 15 years girl has given up after delivery, and he said he doesn't want the baby. So we discussed how we as midwife will build up the mother's confidence after delivery. So therefore today, the postpartum adjustments or the parental stages. We said after delivery, clients go through a lot of stages. And it is when we know the stages that the client go through, then it will be possible for us to manage the client. When we don't know the stages, it will be very difficult for us to manage the client. So it is good that we know all the stages, and then each of the stages, we will talk about the responsibility of the midwife during that stage. Okay, so that is where we got to, and we were given a reading, an assignment. So today we will look at the stages, and research have shown us that after delivery, the mother go through a lot of stages after birth. And each of this stage, the midwife has a responsibility to take care of the mother and then the baby, so that the mother doesn't give up and end up with postpartum depression, which can result in postpartum bruise or which can result in postpartum psychosis. So we are here today to talk about the stages. And I think I have 350 people. So like I said, last week I said when we come, we will start and we won't wait for them because we know that the class starts at 3. So let's quickly talk about the stages. Now, if you look at the stages, we have 4 of them. They are 4. We have the taking in, taking hold. Then we have the letting go. And then where we have the depression. And remember, if we look at the stages, we want to avoid the mother getting to the last one, which is the depression, which is very, very important. So it is very, very important that we, the midwife, we know all the stages, and then we know our responsibility in each of the stages. If you remember last week, I said that after delivery, that is not all. Because after delivery, the mother go through a lot of changes. And changes can occur in each of the stages. And then that is where the mother's vital signs can change and we may lose the mother. At the same time, the baby condition too can change. So if we look at the stages, when we get into the postpartum stages, that is where we have to keep an eye on the mother and the baby because we don't need to neglect them because changes can occur. So let's look at the taking in phase. And we said the taking in phase of infant bonding, it occurs in the first 24 hours after delivery. Remember, last week we talked about the stages of Pueriperium and we talked about the immediate stage. So within the first 24 hours, that is where the mother is in the taking in phase. And here we said the new mother is aware of, especially new mothers, they are aware of her baby and then her needs. But here you find out that the mother focus on getting her own needs met first. Because the mother is tired. The mother is tired. Remember, the mother has been in the process of labor for almost 12 hours or from even 10 hours to maybe 15 hours or so many hours. And the mother is tired. Remember how contraction is a rhythmic contraction, a painful one, of course. The uterus was contracting, retracting, contracting, retracting. And the pain that the mother was going through, during that time, the mother was having loss of appetite and he has been screaming. The mother is tired. The mother is fatigued. And so the mother is tired, the mother is fatigued. And when we get into this stage, this is where the mother depends on we, the healthcare workers. And here the mother seeks support from staffs and relatives Okay, she's aware that the baby is there. So if you look at the image beside the slide, this is the midwife figure, and this is the client. The mother is tired. So here, the mother focuses on her own need first. So you find out that after delivery, within some few hours, when you go to monitor the mother, you go and the mother is deeply asleep. And this is where the mother now starts. Aha, now the baby is out. I feel like I need food. And that is why the mother will ask the midwife to assist her get food, assist her to take care of the baby. And this time, if we're not careful, now that we are doing bedding in, the mother can even sleep deeply. You see, after delivery, they have a deep sleep. Okay, and that is where the stress of labor, they are trying to be relieved from the stress that the mother passed through the stages of labor. And if we're not careful, even if the baby is bleeding from the cord, they will not know that the baby is, if the baby is not lying or well on the left side and the baby is lying supine, they will not know. So you, the midwife, here in the taking in phase, you will have to monitor the mother. So the mother is asleep, you go and check the uterus, is it contracting? If the mother is on IV fluid, is it flowing? If the mother is on the catheter, you look at the perineal pad, assess the amount of blood loss. You also keep an eye on the baby, find out how the baby is doing. Is the AGAP score the same? The breathing pattern, you check the baby's cord and make sure that the baby is not bleeding from the cord. And this is where baby can bleed from the cord and they need to be soaked in the diaper. By the time you go, the baby is gone. So the taking in phase, here the responsibility of the midwife comes in. Sometimes I know that normally I don't want to teach this, but let me add it because let's be what we call, let's face the facts. Sometimes I don't know now. Now we have a lot of midwives, but in our time there were no midwives, but now we have a lot of midwives. But let me also add, sometimes even if you think you are so busy in the world that you are alone, and within this stage, you will not be able to keep an eye on the mother at the same time, keep an eye on the baby, then you can involve the relative. Remember when we talk about, we have skills workers and unskilled workers or unskilled personnel to assist you care for the baby. And the relatives are one of those who are unskilled. Sometimes you may even find out that the relatives, some of them are skilled workers. So you can involve either the relative, those who are around, to be observing the mother, to be observing the baby for you when we're busy, so that from time to time you come over and check. Okay, from time to time you come over and check. So that is the taking in phase. And we said it occurs in the first 24 hours after delivery. And we said during the taking in phase, it may last 1 to 3 days. And here the mother is very passive and independent. He's dependent on the healthcare workers and sometimes the relative in the care of the baby. And you know, those days when you deliver, they will give you somebody, the relative, they will give you a support person to be helping you. They were having a reason for that. But it is now that when you deliver, you want to be alone with the baby and your family or your husband. You don't want any third person to come in because they understand that those stages are there where the mother will need to depend on somebody within the first 24 hours, and it may last for 1 to 3 days. And remember here, the mother concern is about the mother's own need, sleep, rest, and then food, so that he will be relieved from the stress of labor. So from here, midwives, we have a responsibility. We jump into the taking in phase. And so you can see how the mother is happy with the baby. And this is the midwife. So here we said the taking hold, take hold, take power, take hold. Here we will find another mother is independent and is autonomous. And here we said during this phase, the mother focus on learning to care for the new baby. If it's a first-time mother, she now learn from others, experienced people, help me how to bath this baby. Help me how to, if it's the midwife, oh, fine, help me on to attach baby to breast. Okay, assist me on how I am going to change baby diaper. Okay, assist me on how I am going to change this baby's diaper. So here, the mother is ready to learn from others. And the mother take in charge. She take the power in the care of the baby. Now she's fine. She has the strength to care for the newborn. And he manage things that on her own, and he learn from others. Now he concentrates on the baby, taking care of the baby. However, the midwife is not over, because we said the taking hold phase may last from the 3rd day to the 10th day postpartum. But it is not over. Why is it not over? Because especially on a new mother, mood swing may take place. That is where postpartum blues or depression may take place. And here there is a problem. Here, the partner may feel neglected because the mother is more involved with the baby now. And he may overlook the needs of the other kids, or he may overlook the needs of the partner. So here the mother concentration is on the baby. Everything is the baby. Sometimes you go home, where is my food? Then the mother would then oh, today the baby has been crying. I've been changing the baby diaper. I have been doing this. I have been bathing the baby. If I put this baby to bed, the baby will wake up and the baby will cry. It's about baby, 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 baby. And the mother concentrates more on the care of the baby. And she may neglect even the mother's own personal hygiene. The mother will wake up in the morning. That is where you see the pepper mother. Sometimes without a brazier, sometimes their hair, they don't do their hair well. It's about the baby. Everything. Baby. Kakrebia. Then you go and pick the baby. Everything, baby, baby. Baby is crying. Let me change the diaper. Baby is doing this. And if you're not lucky, you get a crying baby here. You will. You forget a crying baby. Every concentration is on. So here he may neglect the partner. And this is where the midwife will have to come in to counsel the mother to be able to balance. Because here, if sometimes if the husband feel neglected, she may even seek, how do we call, attention from outside. And this is where most people may lose their partners. At the same time, they may lose their relationship. And then they will end up coming to the midwife weeping with high blood pressure. You check the BP and the BP is very, very high. And you want to find out, my husband is not coming home again. Because now the mother is more concentrated on the baby and he has overlooked that of their partner. And that is where we have to teach them to balance the two. And here, house help is very, very important to assist the mother care for the baby. Please excuse me. Okay, sorry for that. I have to take some more water. Sorry. But remember, if it's not a new mother, then those who are old mothers, this is where they want to show their experience. Those who have delivered before, and here, when they get into this stage, they will say, oh, I have experience. I have delivered before. I know how to bath the baby. I know how to do this. And you want to put her experience, you want to demonstrate her experience here. And remember here, he may end up neglecting the husband at the same time, the other kids in the house, or he may neglect the other children in the house. And you find out that you go, he was not, see, you ask, why didn't you bath the children to school? She will be giving you an excuse. And today the baby did not sleep, the baby is crying, I have to change the baby's diaper, I have to wash the baby things, and me alone, I'm doing that. So here we also have a responsibility to come in so that things will be balanced. And from there, if we're able to counsel the mother very well, remember within this period, it may start from the 3rd day to the 10th day. The mother may come for the 7th-day postnatal clinic, and we take an opportunity to counsel the mother. So if they're able to balance things, then they will now come to the letting go phase. Okay, letting go phase. Let go. So here the couples will continue their relationship that they had before the birth of the baby. An interesting phase. Here now, mother has been able to balance. Now he's balancing the care of the baby at the same time taking care of the husband. So now they, as first, before the baby came in, they were going out for clubbing, they were going outing, they were doing things together. They were in love, deeply in love. But now that the baby came in, things were messed up here. The husband feel neglected. Why don't I go for a side check? But with the help of the midwife, the mother has been able to build or to manage things as they used to be. And the mother will come to the letting go phase. And here they will continue their relationship before the birth of the baby. So now they may even decide to leave the baby to the caretaker, and then go out and enjoy some more together, dress up, go to occasion together. But remember, as they are going, they are also not just neglecting the baby. They also keep an eye on the baby. And here, older brother or sisters get to know the baby at this time. So here, the mother introduced this baby to the other children in the house. And here, they will begin to, you see, the mother begins to resume her normal activity as she used to do. And here the partner will not feel neglected. Now they are together. So now everything is okay. If it's about dressing up for sex, she resume everything, going out with the husband, taking care of the kids, bathing them to school, and then she's able to manage things, everything together. So now he has let go of the taking hold phase. And here we can see that midwife will be very happy for the mother to get into the letting go phase. Okay, so that sometime here they may even end up, for example, even if the mother wants to start work, he can even start work here. Either you leave the baby with a caretaker, or now we have a crèche that we can even send the baby there. Now, the baby is now part of the family unit. Everybody is taking care of the baby. So the mother has more hands here and everything is fine and they are happy again. But most people give up here. Sometimes, if I'm not lucky, this is where the problem is. Because if I neglect your partner, neglect the other children in the house, and then something happened, are you with me? Something happened, and then now, what is happening is that now they have neglected all those things, and now the husband is having, but husband go out, doesn't come in again. And this is where the mother will start thinking, why is my husband doing that? Sometimes my mother may even, you see, because she's keeping an eye on the baby. If he has another children in the house, even if the person falls sick, he will not even notice that her baby, the other case has becoming anemic, so they should take action. She may even end up losing either some of them or even all. And that is where, when we are not careful, they may jump this stage and come to the depression stage. And that is why I don't want things to get bad. Okay, so when they come to the depression stage, you can see the image, the mother is depressed. He has given up. He doesn't even care of the baby again. And sometimes this is where, if the mother doesn't get help, if we're able to counsel the mother, you see, remember, that is why we have the family centered. It's not only the mother, but you also counsel the partner, so that they all together help with the care of the baby, so that the mother can get here. But if the mother is alone, the mother alone is taking care of the baby, the mother is also doing all the household choices, the mother may give up. It may end up with the depression phase. And that is where we don't want the mother to get to. Because if the mother gets here, then it means we have a lot of work to do. If we are not able to pick up fast, the mother may end up with a serious mental condition, which is the psychosis. Okay, so that's a responsibility. So, for example, if the mother gets here, we also have a responsibility. It's not too late. We can still come in, balance things. And we have been seeing them in our facility. So then the mother will come for the postnatal clinic and you check the blood pressure. Okay. I'll open up for us to discuss. You check the blood pressure and you find out that the blood pressure is around 200, 180, 160, 100. And if you sit the client down and find out what is happening, the client is going to tell you a lot. And you find out that things are in there. The stages didn't go on well. Okay, so here quickly we will manage the client before the client goes through to the psychosis. So now let's open up for just share your experience with us. Maybe you didn't know that there were stages like this. Now that you know, have you ever have a problem or have you ever come across a client who was going through all these stages and you identify to help? So let's share. We are using 3 minutes to share experience and then we'll proceed. So share with us, have you ever managed a client and now you know the stages, the client go through all the stages, or there was a problem that you find out, you were able to identify and then you were able to manage? Yes, can we get, please, you can put up your hands and then I will call you for you to share with us. Don't mention the hospital and don't mention your name. Yes, anybody to share with us. Yes, anybody to share with us. Have you ever, maybe you have worked in the postnatal clinic or ward and you find out that something happened through the 4 stages and you have to come in to help the client. Please, anybody, you can put up your hands. Anybody. We are discussing. Yes, I know you are muted. You put up your hands. When you put up your hands, then I will ask you, I will unmute you for you to talk. Let's do it that way. Okay, so ask to unmute. Okay, so I have, please save your name with your index number because when you contribute in class, you are going to get a mark for it. Musa, let's go.
Yeah, it happened to me myself. In fact, when I delivered my first child, I didn't go through these stages. I wasn't taken through. So by then I was a community health nurse. And then I went to stay with my in-law. This baby cries a lot. And the grandmother will be complaining. And I'll be so to do. So it goes to a time she'll be crying and I'll be crying. I didn't know it was going to affect me. I'll go to hospital, my BPs will be going up, I can't sleep. This baby is always crying, and I'm also crying. So, and I was also reducing in weight because I wasn't sleeping. So later, my husband came in and said, no, it seemed there was something wrong. And sometimes she'll be crying, and instead of me to breastfeed, I will just be looking at her and also be crying. So we went to the hospital, and then when they even take the baby from me, I'll just be looking at them because I didn't know what was happening. So one psychiatrist nurse said, no, I think this lady has a problem. And then he talked to me that I should accept what is happening and accept that if the baby is crying, I should just pick the baby and then breastfeed and those things, because how she was behaving was like something new to me. So when she's crying, then I'll also be sitting down and crying with her. So I was taking through counseling and things to accept that she will change, and gradually breastfeeding. Then this baby started reducing the crying small. Then I accepted the situation, but I wasn't given any medication. It was only talking. I was just counseled, and gradually I accepted, and later on everything subsided and I was okay with the baby. That's my experience myself.
Okay, thank you very much. Add your index number to your name for your mark. Please, anybody else, you can put up your hands. We have 5 minutes. Please come on board and let's do the discussion. Yes. Anybody to share with us? Okay. Mara, today I have a problem with my voice, so I've been taking water like that. Mariam, please, you can talk. Hello. Okay. Anybody to share with us?
Good afternoon.
Okay.
Please,
Please, nobody should share in the chat box. This one is an open.
It's part
chat.
of them.
Okay.
I was just buying items. I'll go and buy this. Any money that comes into my hand, I feel like buying.
Okay. We are with you.
Deliver the items she brought. Meanwhile, we gave her a list too. But the items she brought was just out of context.
Oh, please, can you hear me?
I want to know.
Can you hear me? Oh.
If
hello.
It's also part of the.
Miriam, please, can you hear me? Your network is breaking. We can't get you.
I said it.
Yes.
At a postnatal stage, mine was I feel like buying.
Okay.
Anytime I feel like going to the market and buying. So it was now, it got to a point I was now, when I look at the baby, I asked myself, is this baby from my tummy? At that time, I wasn't a midwife. I was still a student, community health nursing student.
Okay.
So recently, that a lady too came to deliver. The items she packed to deliver. Meanwhile, we gave her a list too. Was just out of context. Later on, when we're now asking her of the items, she told us that it's in the house. She rather brought something that we don't even need at the labor ward.
Okay.
So I don't know whether that one too is part of the postnatal stages.
Yes. Your own, the things you don't need them, but still you were buying them.
Yes.
Was it things related to the baby?
No, not. I'll go and buy cloth, go and buy sandals. I was like, the baby too, I'll buy this, what is the name? The big. Instead of me to buy 3 or even limited number, I'll go and buy. Next time when I go and see it looks beautiful for me, I'll buy again. Like buying double things. Anything I see is like catching my eye for the baby and I. So it got to a time I wasn't making money to be by me again.
So you were in the second phase, the taking hold phase.
Okay.
You were more concentrated on the baby and everything, baby. But your clients, the one you were talking about, did you do that? Did you refer to see the doctor for the assessment?
Yes, like for her, the one we even follow up, they have to move to a different community. So we release her to the next level of the clinic to take care of them. When they deliver, they move to their husband's family.
Okay.
She was with the husband.
I think everything is solved now.
It's now fine. It's fine, but it's still like when you look at her, it's like already she was having a background of a mental problem a little.
Yeah. So sometimes when you have history of mental, that is why when we are taking the history, we ask, do you have any mental condition in the family? Sometime after delivery can trigger hormonal imbalances, returning to its normal stages can trigger and then together with taking care of a new baby, taking care of the baby, all those things can be a contributing factor. But we thank God that the mother is fine now. So please, this name, is it Rafitu? Yes, is it Rafiatu?
Yes, ma'am.
Okay. Yes, okay.
Please, what I witnessed was during my service.
Yes.
So the woman, she was a first-time mom who came and delivered in the facility, and they discharged her. When she went to, after a week or so, they came back with the baby severely jaundiced.
and the baby
Okay.
was irritable, crying, and then she came with the mother-in-law. And sometimes the mother-in-law will be sleeping, the woman will be taking care of her. By the third day of admission, her mom, the baby, the postnatal mother was now distant, like he was isolation from the baby. Before they realized, the mother was getting aggressive. So they have to separate baby from mother and send mother to the gynec ward and leave the baby at NICU. She was still aggressive, not agreeing to breastfeed. Until after some time, they involved the psychiatric unit. Then the woman got used to a particular nurse. So it was that nurse who convinced her to breastfeed. So once the nurse is on duty, that midwife is on duty, she will go and talk to her. And there was language barrier too. So it was actually making the work, counseling very difficult. It took time until baby was discharged and mother started breastfeeding, and gradually they were bonding again. But the psychiatric nurses had to come in because she was getting really, really aggressive at a point. A day was there, she just sat on her buttocks throughout the day and throughout the night. No sleep.
Mhm.
That's one of my experiences. Thank you.
Thank you. Martha. Martha.
Hello, sister.
Yes.
I want to share one of my experience.
Okay.
One of my clients also, with her firstborn, after 6 months, the child developed hydrocephalus. We didn't notice it till 6 months when the head started swelling. So the child got to 3 years and she got pregnant again. When she came to the hospital, her BP, she had PIH because she was afraid that the next child too will get the same thing. After delivery, this lady couldn't breastfeed the baby. She was saying that, no, this baby may develop the same thing and it will be a burden on her. So she doesn't want to breastfeed the baby. She denied the baby for 1 week. So we have to call the family members together with her and send them to the psychiatric unit for them to help the lady out. So we left them with the psychiatric nurse. 6 months later, the baby didn't develop that one. So I was following up with her. So she got happy and all the pressure also came down. Because for the first 6 months, the lady was having blood pressure due to that because she was afraid and anxious of the previous incidents. That was my experience.
Okay, thank you very much, Benis. Thank you, Benis.
Okay, sister. Hello.
Okay.
My own,
So after Benis, followed by Ernestina. Okay, Benis.
My own, when we were posted at first, I went for one night shift and one lady came and said, sister, I have seen that some fluids are coming from my vagina. Some fluids are coming from her vagina. And I said, okay, where is your AMC book? Say that, and so I will go and assess you. And she said, me, I'm not pregnant too. I just saw the fluid coming, but her tummy, was a little bit big. So I assessed her and realized at that time she was 9 cm dilated. So I told her and said, it's not true. When the tummy was becoming big, she asked someone and the person said, there is something in her tummy. So the person has been giving her medication to take. So it's because of the fluid that she came that day. Later, she delivered. And in the night, I saw that one baby was crying. And after that, we explained everything to her and she became okay. But after delivery, the baby was crying. I didn't know it was even her. So when we went, she was sitting down and the baby was somewhere. So I asked her why she's not breastfeeding. She didn't mind me. So I picked the baby and tried giving the baby to her. She just threw the baby at me. She just threw the baby at me and I asked her, why? And she also asked me, do you have a child? And I said, no, she has to take the baby. And I said, no, you want me to take take care of your baby. When she goes, you come back and take your baby. No, I won't take it. But we realized that something was wrong with her. So we called someone, and the person came and asked her so many questions. And later we realized that the husband was maltreating her and also cheating on her. So the psychiatric nurse people came in. And later, before she was discharged, she was okay and embraced the baby and started breastfeeding the baby. So that was mine.
Okay, Ernestina, it's your time. Ernestina. Okay, Rita. Rita.
Hello? Hello?
Please, we are waiting.
Hello?
We can hear you. We can hear you. Go on.
Okay. Sister, please, just the day before yesterday, I was going for a night shift. So when I went, the afternoon staff, they were making noise, talking, that there was a woman at the ward, lying in ward. She delivered through CS for 3 days ago, and we're still transfusing her. So they went for the medication, and she said they should change her baby's diaper for her. They didn't do it, and they are giving her some kind of blood. She was talking, insulting the nurses because she said they should change her baby's diaper. Meanwhile, she's having caretaker, and the caretaker, she said the caretaker should not touch her baby. So she was doing that, and the nurses were all talking. So, but when we went for night, and we changed the diaper for her just once. Because when she was behaving that way, they said maybe it's something. But when we the second phase or the third, because they did the CS 3 days ago. And right now she's still at the ward. That's my experience. Hello? Hello?
Okay, thank you. Rita. Hello, Rita. Rita. Okay. Zina. Zina.
Good afternoon.
Good afternoon. We are with you. Go on.
Sister, my experience was just this last 1 week. I went to work. It was in the morning, and then a client complained to me that one of the patients are over there crying, and they are just talking to her. She's not listening. So I took my time to talk to her. I asked her why, and she's like, I've not seen my baby. So, and when I resumed to work, I didn't even know about her. So I went back to ask, and they told me that the baby is at Nico. So I came back to tell her that if your baby is alive, definitely the baby is really at Nico. But if the baby was not there, they would tell you the truth. I don't see why they will hide it from you. It's true that the baby is not feeling fine. That's why they sent the baby to Nico. So you, a size patient, and get breast pump, should in case they need breast milk, they will call you to do that. So me, I just talked to this lady, and I thought like she understood me well, and she's calm. I went back to the nurse's station, only to realize that she stood up from her bed and started crying loudly. And you could hear her from afar. So I went back, and she was like, she wants to see her baby. I said, okay, fine, don't worry. I'll personally send you to the NICU for you to see your baby. Will that be fine? She said, okay. So I told her to wait. I will inform the NICU people before I bring her. So I went and told them, and I said, no problem, I should bring her. I went and brought her to the NICU. Immediately we arrived, they were like, Ma, why are you crying? We are even a staff there, even though she's not a nurse, she was a lab tech. So they told her that, oh, the baby is not feeling fine. That's why they brought the baby here. But now that you are here, it's good we give the baby to you so that you can breastfeed. And this lady said, Lala, she's not even touching the baby. Everybody bring her mouth to talk, and she said no. She doesn't even want to look at the baby. And she was still crying. The minute to give the baby, she said no. She walked out from the NICU. She was now at the entrance of the NICU crying. Everybody was now looking at her. So we have to call the senior staff to talk to her. Actually, we were having a workshop, so I didn't even follow up to see what happened next. So earlier, I even forgot we have something called psychosis. So I was surprised with her behavior. Then later, people were like, maybe she's having psychosis. I said, okay, it can be that. So I couldn't follow up because of the workshop I was having. And that is my experience.
Okay, thank you very much. I think now we were having a group work which we are discussing now. Mention 4 problems. Postpartum adjustment problems. So this is what we are all sharing. And remember, each of the stages, my concern is you, the wife, you have a responsibility to do. So let me call the last person. The last person is Rita Sapon. Oh, Rita Sapon. Yes. Rita Sapon. Your hands is up. I saw Justina. I saw Justina hands also up. Okay, Nana. Nana Kosia. Okay, I don't know. Nana.
Yeah, sister. Somewhere last year, a client came to deliver at our facility. I didn't know there is a stage like this that you need to follow. That will let the baby, like, as you have taught. After delivery, she wasn't caring for the child. She eats, leaving the child. If the child cry, he doesn't even attend to the baby. He don't do anything. He will bath, sleep. So I went to her and tell her that, what is it? You've eaten fufu banku. Now they've given you porridge. And you are not even breastfeeding your child. You've been feeding your baby with dextrose and you don't even care. This one just look at me and laugh. I forced her to breastfeed. I expressed breast milk for the baby. So on the day of discharge, I educate both her, the husband, and one relative. It was then that the husband informed me that that is the nature of the wife. The first time that she delivered, she didn't care for the child. He, the husband, took care of the child. They are having even electrical breast pump, but the woman doesn't want to do it. So I asked her what is the problem is, and this is what she told me. She feel that the baby is stressing her too much. So she don't want to like neglect herself, leaving herself and caring for the baby. So the husband should continue with it. I thought it was normal until today that you've taught it, and I feel bad that I couldn't do anything for them.
The client you are talking about was still in the first phase and he doesn't want to move. So now that you know, I don't know whether it's too late. You can find them and see what is happening now, or it's too late. I don't know whether it is too late. Can we proceed? Okay, Nana, your hands has been up. Let me call her. Nana Kusia.
Okay, sister, with my experience, it happened, I think, during our last clinical days in school. There was this woman on the labor ward. When she came with the complaints of labor pain. So they monitored her, so she was fully dilated. And then when it was time to push, she wasn't cooperative. And the midwife didn't understand why. We spoke and spoke and spoke to her, and we were all not her tribe mates, so we thought it was a language barrier because we were only using Twi and then English. Most of us couldn't understand her well, so we thought it was language barrier, not knowing it wasn't. So later on, when she gave birth and then we took her to the line inward, the pad we gave to her on the labor bed, we told her to pick it out and then change after some few minutes, then urinate. So later on, when we went to check on her, she had taken off the pad and then rather left the pants like that. She had no pad on her, and the blood was also oozing out. So she was dripping all over the ward, and she was walking around. And I don't know why she kept this black poly on her hair. She removed the hair net they made her buy on the ward, and she kept a black poly. They asked her why. She said it was that one she wanted. So later on, her relatives came and the baby, she didn't even want the baby on her bed. She picked the baby to the next patient's bed and kept the baby there. We asked her to breastfeed. She said no, she just wasn't cooperative. So it was later on, the midwife said, oh, this woman, she has psychosis, but whenever they give her the drugs, even after the delivery and during pregnancy, when she starts getting well, then she stops the medication. So it's like whenever she gets into labor, at a point she switches off and then goes back to her psychosis. Then when they treat her and she's getting better, she stops coming for medical attention. So that's my experience.
Okay, I think I should call Rita. Thank you. Rita, you are the last person. Rita. Oh,
Hello, sister.
okay.
Hello.
We can hear you. Please go on.
It was about a client. When she got pregnant, her husband told her that he is not the father of the baby. He did not impregnate her. So the woman started thinking about this pregnancy before labor. And during labor didn't progress well, so she went for CS. After CS, the mother also came and was insulting her. The lady will get into another situation, and it's happened. The lady was served with food and she didn't eat. All that she was doing, crying also, and she won't speak for her. Even if you give the baby to her, she won't even hold the breast unless you hold the breast, put it into the baby's mouth for the baby to suckle. They came and diagnosed her of depression, and treatment was given to this lady. She was being discharged home, and 3 days later, she went and collapsed and was saying her ancestors was calling her, so she was going. And they brought the lady after some minutes. With her and they were sorting her. She's not happy, so she's in support. That's why this lady was get into this condition.
And okay, thank you very much. Thank you. Okay, so I think that is we have learned today. And I think from today going, we will look at the stages. Then we will look at how we will be able to help the client. For the stages, we will look at how we will be able to help the clients. Okay. Okay. Can we proceed? Somebody, I saw another hands. So we are moving to the physiological changes. Now we know that we have done talk about the postpartum adjustment, but what about the physiologically, the changes that is going to take place? Okay, so we are going to look at them, and we said there will be reproductive system changes in the uterus. Remember, we said there will be involution of the uterus, and when we talk about involution, we are talking about the changes that the reproductive organs, that is the uterus, the cervix, the vagina, okay, they undergo through after childbirth to return to their non-pre-pregnant state. Remember, during pregnancy, there was physiological changes. So with the reproductive system, there was changes in the uterus, there was changes in the vagina, there was changes all over. Now, after delivery, the reproductive organs will have to go back to their non-pre-pregnant state. Okay? They will have to resume back to their non-pre-pregnant state. And this is where we also have a responsibility as midwives. What do we see? When they come for the postnatal clinic, we just ask them, Mommy, okay? We ask them those questions. We ask them, Mommy, the lock here, is it coming? What is the color? Instead of us to do our physical assessments and do what is necessary as midwives. So we are looking at the situation. And we said after delivery, within 12 to 24 hours after delivery, when the midwife palpates the fundus, you will find out that the fundus has rise to the level of the mother's umbilical cord here. And we said the uterus will have to reduce 1 centimeter or 1.5 centimeters every day. And the reason why there is an increase in the fundal height within the 12 to 24 hours after delivery is as a result of the lower uterine segment. The lower uterine segment is regaining its own. That is why. However, we should be able to differentiate between the normal and abnormal. I think when we get to the abnormal, we will talk about some involution. So here, we should be able to differentiate the two. So when the mother comes in, we're expecting that this is the mother's third day. And so you expect the uterus to reduce maybe by 3 cm or maybe by 4 or 5 cm, depending on the mother ability to exercise very well. But still there is an increase in the fundal height. Then you should know that there is a problem. But what do we see in our ward after delivery? Do we measure the fundal height and record? So that if the mother comes for the postnatal clinic, we will be able to compare and see if there is a reduction in the size of the fundus. Do we do that? Most of us overlook it. We think it is not important. So after delivery, we just massage and we don't measure. But remember when you were doing your diploma, you were doing family-centered maternity care study and you were plotting the mother chart. Now, where is the mother chart? The mother chart is no more in the world. But when you go outside, those who are practicing outside, they are using the mother chart. But you remember back in your NTC, you were plotting the mother chart and the baby chart. What happened to it? I will be very happy if we can still bring back the mother charts and the baby charts. Other hospitals still have them. No, though we are not using the folder, but the mother chart and the baby charts, you can do it and you start plotting. So that at least, even if you won't do the mother charts, you can write down the fundal height after delivery. So that when the mother comes for the postnatal clinic, you'll be able to compare and see if there is a reduction or not. Then you find out what the problem is. It may be that the mother is not even exercising. And remember the shape. We said in the non-pregnant uterus, what is the shape? A pear shape. So after delivery, we expect the uterus to go back to the pear shape. That is why examination is very, very important. Examine the pepra mother to find out if the uterus has returned to the pelvis. And is this reducing by 1 centimeter? Okay. Then we look at the size, but we said by the end of the puerperium, the uterus will measure 7.5 centimeters long. Remember the non-pregnant uterus, 7.5 centimeters long, 5 centimeters wide, 2.5 centimeters thick. And then the weight, it depends on the book that you are using. 59 grams. Other books, you will see 60 grams. Okay. But the most important thing is that the uterus going back to its side. And we have a responsibility. And our responsibility is to help the mother, teach the mother the food that the mother will eat. We have special food that the mother will have to eat. That will help. I think when we get to the education, I'll talk about it. That is going to help build the uterus and help the uterus to regain its tone and help the uterus to go back to its non-pregnant state. Okay, you teach the mother the postnatal exercise. I think I will talk about it next week. And then the mother will be able to do the exercise to help the uterus to return to their non-pregnant state. And it is very, very, very important. Let's look at the endometrium, the microscopic structure of the uterus. We all know that the uterus was having 3 layers: endometrium, myometrium, and then the peritoneum or the peritoneum. Now we said the endometrium, there will be regeneration of the endometrium as soon as after delivery. Okay, so that the mother can now resume back to the normal menstrual period. And then what happened to the myometrium? That is the muscle layer. You remember when you were doing pregnancy, you talk about an increase in the size of the uterus during pregnancy. Okay, so let's go back. We know that during that time, there was an increase in the size of the uterus. And so after delivery, the uterus cannot remain bulky. Okay, the uterus cannot continue to become very bulky. It has to go back to its non-pregnant state. And we find out that during pregnancy, there was an increase in the size of the uterus, about 10 times its normal length. Okay, and then about 5 times to its normal thickness. So here, after delivery, there will be release of an enzyme, which we normally call the prophylactic enzyme. And they will be released into the system to digest extra muscle fibers that's increased during pregnancy. And that is known as the process of autolysis. And we said when that happened, then phagocytosis will take place. Okay, that is where the end product of autolysis are removed by the phagocytic action. And then when that happened, this is where at this period, the mother will have the physiological diuresis. This is where the mother is going to have frequency of menstruation because there is a breakdown of the excess muscle fibers in the form of urine. So here, the mother will be having the phagocytosis, will be passing a lot of urine at the same time. And then here we said, during this period, the midwife will have to educate the client on personal hygiene so that he doesn't end up getting UTI or any other infection, which is very, very important. And we said within this process, some of the muscle fibers which increase in size I don't know whether I'm moving so fast. If I'm moving so fast, please type for me in the chat box. Okay. So we said here, some of the muscles may be unaffected by the process of the phagocytosis. Okay, some of the muscles may be unaffected. So when some of them are not affected, you see that most of them, especially in the multiparous woman, please, somebody is writing on my screen. Sorry. Please don't be writing on my screen, please. If we do that, I have to close it and then go and reopen. Okay. All right, so we are here. Then we say some of them, you see the increase in the muscle fibers, and during this process, some of them will be unaffected by the phagocyte or the phagocytosis action. And that may result in a bulky or big abdomen in the multiparous woman. So though sometimes some people have delivered, okay, they have delivered and after delivery, they still have big abdomen. Now, their big abdomen, you will find out, oh, Sister BOAHEMAA, all this process that you are saying, you said all this process will take place so that the uterus will be able to go back to its non-pregnant state. But how come after delivery, some people still have big abdomen? Though these processes are there, we all know that it is going to take place. However, you, the midwife, you need to still come in and educate the mother. Some of the things that account for big abdomen in the multiparous woman may be as a result of eating late at night, maybe as a result of lack of exercise. So if you think that, oh, by nature, enzymes will be relieved or released to digest extra muscle fibers, which increase inside during pregnancy. So, and they will be removed by phagocytosis. And so let me continue to eat. Still, you end up getting the big abdomen or large uterus or big abdomen. Let me put it that way. Okay. Because though these processes is there, but we also have to do physical exercises and then look at our diet so that the process will be complete. Okay, it's very, very important. So as we know all this process, we still have to educate them on how to go about their exercise and then their diet. Then we look at the ischemia, and we say here, after delivery, there will be contraction and retraction of the uterine muscle fibers. And this is as a result of the release of oxytocin from the posterior pituitary gland. And we all know the functions of oxytocin. We said oxytocin helps the uterus to contract. So after delivery, the uterus contracts and retracts so that the uterus can go back to its non-pre-pregnant state. So as the uterus contracts and retracts, then the amount of blood supply to the uterus will be reduced. Okay, if the uterus is no more getting blood, what do you think it will happen? And it will also help to reduce the placenta size. So if you find this also help in the control of bleeding. Okay, the ischemia, it helps with the control of bleeding. And that will help the uterus to return to its non-pre-pregnant state. And you will find out that with time, the placenta size will be covered by the endometrium. But here, let me talk about the process. Those who are tutors in this class, I think there is a problem with this process. I don't know. For me, I think the last time I was discussing it with someone, but in our books, this is what we have. We have this process, the three processes. But if we look at it very well, the first step should be ischemia. This is not the first time that I'm saying this. And I think you will agree with me. Because if we look at the changes in the myometrium, the muscle layer, that is the bulky aspect of the uterus, you'll find out that just after delivery, within some few minutes, should I say minutes or seconds after delivery, then we will find out that the uterus will have to start to contract and retract. And as the uterus contracts and retracts as a result of the posterior pituitary gland, you see, the moment the oxytocin is released, then the processes will start. And there will be contraction and retraction of the uterine muscle fibers. And as the uterus contracts and retracts, you'll find out that the placenta side, the amount of blood supply to the uterus to the placenta side will be reducing. And that even help with the separation of the placenta. Are you with me? That is why if somebody delivered and then the placenta is within 3 minutes, still the placenta is there, we sometimes put the baby to breast, give oxytocin. That is why we give the oxytocin within the 1 minute. So if you look at the process, the first one should be ischemia. But our books, we have the ischemia to be last. So me, I always question the ischemia because the first thing that happens after delivery is contraction and retraction of the uterus. It's when you see the uterus has contract and retract. Then if you look at the abdomen of the client, you see that sometimes when the uterus is contracting and retracting, then it becomes, I don't know how to put it, but a storage napkin. Let me put it that way. Now, so that should be the first. Then followed by the enzyme that will be relieved, the prophylactic enzyme that will be relieved to digest the extra muscle fibers. They come and eat it, so that as they digest them, okay, then the phagocytosis will also come in. Then they'll break it down, and it may end up the mother may have the passing a lot of frequency of mutilation within the first 48 hours, which we normally call the physiological diuresis or something. So if you look at the process, and I think I was discussing it with someone, and the person was asking us, oh, maybe we can write sometime when you find it in the book. But if you look at it, this is the first. So if you get a tutor or a lecturer and the person teaches the ischemia first, the person is not wrong. Because if you look at this one should come first. That is my opinion. So I don't know whether you have also have any this thing like that. Okay. So we are back to the lochia. And we said we have, what is lochia? So when I was talking about the ischemia, you remember I talked about discharges coming from the uterus after delivery or abortion. Okay, discharges coming from the uterus after delivery or abortion. So somebody would define lochia as discharge coming from the vagina. Please, it's not coming from the vagina, and it is coming from the uterus. And if you look at the term, it comes from a Greek word, which means it is relating to childbirth or maybe abortion. And we said lochia is alkaline. Because it's alkaline in nature, if we don't counsel the client on personal, especially vulvar hygiene, changing perineal pad frequently or on time, then it means the mother has a high risk of getting infection. Because we all know that alkaline base attract pathogenic microorganisms. And they like it. It's a good medium for them to grow and multiply. That is why we encourage them to wash their hands, change perineal pad on time. And then when they change the perineal pad, they should wash their vulva anterior, posterior direction, front and back, so that they don't end up getting an infection. So anytime you are educating your clients on how to take care of you have to add and let them know why there is a need for them to change their pad, because there is what lochia is alkaline in nature. And then the odor is heavy. When we say heavy, when you look at our menstrual flow, you find out that our menstrual flow is not offensive, but it is heavy. I don't know whether you understand me. Okay. So the moment you find out that the lochia has become offensive, then it means an infection has set in, because it is not offensive. Okay. It is not offensive. So we always how the client is going to take care of herself with the lochia. And it is very, 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 very important that we know how we are going to educate the client. If the clients know that, oh, you can get infection from this, They will be able to take care of themselves. And then you let them know that, oh, it's like your menstrual flow, heavy, but it's not offensive. Anytime you find out that it's offensive, please report to the hospital. Or anytime you are bleeding in clot, okay, report to the hospital. Then we have 3 types of lochia. We have the lochia rubra. So I've used the color red. We said it's red in color. And it is the first thing that the client will see within the first 3 to 4 days after delivery. So the first 3 to 4 days, you find out that the client will have the lochia rubra. That is the discharge that will be coming out. And we said it is bright red in color. And where do you think it will be coming from? Remember when I was talking about the changes? And we said it is coming from, it is because of the contraction and retraction of the uterus, trying to control bleeding with the oblique muscle fibers. Then the amount of lochia fluid will also be reducing and changing. So I always tell my students that the color of the lochia give you the color of the lochia tells you the healing process of involution. Okay, let me put it in that way. If you are a midwife, you will be able to use the color of the lochia to see if your client's, the uterus, inside the uterus, is because if you look at it, you cannot see inside what is happening. But the only thing for you to know is the color of the lochia, and it is coming from the placenta side. So if contraction and retraction is going on well, then you'll be able to know. If it's not going on well, you will also be able to know. And we said it is the first, coming from the placenta side, first 3 to 4 days. That is what you are going to see. And we said it's from the placenta side. And then at the same time, it may be a debris arising from the deciduum. That is the lining. Remember, when you are pregnant, we don't call it endometrium, we call it the decidua. And then remember, it may also be coming from there. Then we said, as involution is taking place, okay? As involution is taking place, the color of the lochia will be changing. And that is telling you, oh, the uterus is healing and it is returning back to its non-pregnant state. Oh, the uterus is returning, everything is okay. That is why we as midwives, we should always look at the color of the lochia. When a mother comes to us, we should not ask them for them to tell us. So we have the next step is the lochia rubra, seriosa, sorry. And we said that is the discharge for the next 5 to 9 days. And what is the color? So I think we said the color can be pale color here. Now, we said that here, when you find out that the lochia has become pale pink or brown in color, now it's telling you, the midwife, that there is a less blood. It means contraction and retraction. Now the blood coming from the maternal circulation is reducing. So it is telling you, the midwife, that there is a less blood. And it's also telling you, the midwife, that it contains more serum, and it is also containing a lot of leukocyte or white blood cells. And we all know that white blood cells are responsible for healing, okay, fighting any infection, and they are responsible for healing or fighting any infection. So if it contains a lot of the white blood cell, then it is telling you the healing process is taking place in the uterus. And it may also contain tissues from the placenta side. And we said normally the amount of bleeding, is moderate, it's not heavy. So the amount is heavy. Then it is telling you what is happening with involution. There is a problem with healing, and there is a problem I need to find out. And I always tell my students that after delivery, the uterus doesn't like any foreign body inside. That is why we said after delivery, massage the uterus to expel blood clots. And we said when you are massaging, just massage abdominal. Don't put your hands into the vagina like you want to bring something in from inside out. The moment after delivery, you put your hands into the vagina, you are going to disturb the processes. The clotting, the contraction and retraction, that is forming the closure. You are going to bring that clotting out, or that process, you are going to interrupt with the process, and then the uterus will have to work harder to control bleeding. So I always tell my students that after delivery, just massage the uterus. Don't pack the client. Again, don't pack the client. Don't put perineal pad. Don't squeeze perineal pad inside the vagina, because you may end up causing an infection, and you may interfere with the physiological changes during puerperium. So after delivery, just massage and then apply your perineal pad to the vulva, and the client will be fine. Then we have the last stage, which is the lochia alba. And we said the color is pale white. Normally, I always look at the creamy color of idioma to teach my students. And it is telling you that, we said it is telling you the it is telling you that it contains more cervical mucus. And it also contains a lot of white blood cells. And it also contains the healing tissues from the placenta side. So the moment you see that the color has changed to a pale white, then it is telling you, the midwife, that, oh, healing of the uterus is complete and everything is fine. And we said it may continue during from 10th day to 2 weeks or 6 weeks after delivery. And we said it is telling you, the midwife, oh, everything is fine. Oh, now healing has taken place. Evolution, the returning of the uterus to its non-pre-pregnant state is complete. Client did not have any infection. There's no interference, or there was no complication with all the 3 stages of the lochia flow. So if by the 10th day, the clients are still having the lochia seriosa, then you should question yourself, by the 2nd week, still seriosa, or by the 10th day, lochia is still red. Remember, I said the uterus is made in such a way that after delivery, if the fetus, she doesn't want anything inside again. The uterus wants to be free. So if there is a retained product, then the uterus will try to get rid of it. Okay, she just wants to get rid of the retained product that is left in the uterus. So he will try to get rid of it. Go away, go away. And in that process, it may even result in still PPH, or it may result in having the lochia rubra at maybe on the 5th, 6th, 7th, and 8th day. And sometimes too, it may result on it may be as a result of poor personal hygiene from the client, introducing an infection. And then sometimes with the midwife, after delivery, putting your hands inside the vagina to bring out whatever is inside, and putting perineal pad, because I know a client that they put perineal pad, and the midwife told the client that you should remove the perineal pad and then empty the bladder within some few minutes. And the client did not understand. So he sent this perineal pad room and returned back 2 weeks later with an offensive vaginal discharge. And when they removed the perineal pad, it was green in nature. And that is telling that the process, the physiological process, the normal process has been altered, and an infection have set in. And remember, you don't want to do that, because if an infection sets in, remember the placenta site is exposed. So the moment an infection sets in, it goes straight to the placenta site. and then straight to the maternal system, and we may alter the physiological changes. So we as midwife, we have a lot of responsibility that we will have to teach our clients. So we say, explain how oxytocin aid with involution of the uterus. And I think I have explained it. And then the next one, explain the meaning of lochia or the being heavy. I think I have also explained that. Okay. Now let's move to the changes in. So normally when we get to the breast, we talk about the physiology of lactation. And we said the physiology of lactation is in two forms. We have the production of milk and then the passage of milk. And each of these stages, we have a responsibility as midwives. Okay. Now we have production of milk. And we said the production of milk is under the influence of a hormone called prolactin. We all know about prolactin. And then the passage of milk is under the influence of oxytocin. Okay, so the production of milk is also known as the milk production reflex. The oxytocin, it is also termed as the leg down reflex. Okay, so we also have either the milk ejection reflex or the let down reflex. And each of them has a responsibility that the midwife will have to come in and help the client. So let's quickly talk about the stages. Now let's look at the physiological changes of, or the physiology of lactation. Okay, so here, remember I said we have two factors influencing the physiology. Remember we have the production of milk and then the passage or the flow of milk. And then the production of milk is under the influence of prolactin, and then the passage of milk is under the influence of oxytocin. So the production of milk. Now, remember, just after delivery, the midwife give oxytocin within 1 minute after delivery to help with the expulsion of the placenta. So after delivery, you deliver the placenta. We all know the functions of the placenta. During pregnancy, the placenta was producing estrogen and then progesterone. So the moment you deliver the placenta, within that short period, these hormones, that is the hormones will go down because now the placenta is no more to produce progesterone and estrogen. So the moment the placenta is expelled, then progesterone and then estrogen level will go down. And the moment they go down, now it will help the anterior pituitary gland to relieve the prolactin, which is responsible for the production of milk. But we all know that during pregnancy, prolactin is there, but we normally say that it is produced, but it is not functioning until after delivery, when we have delivered the placenta, and then the anterior pituitary gland now release the prolactin into the mother circulation. And when that happens, what do you think it will happen? Straightforward, prolactin will be relieved and then to the maternal blood, and then it will go to the breast. Okay, this is the breast. And when it gets into the breast, what do you think it will happen there? We said the moment please, somebody is writing on my screen. The person should stop. So it will go to the breast. Now, when it gets into the breast, this prolactin will act on the acini cells. So let's go back to anatomy of the breast. Okay, it will act on the acini cells, and then production of milk will start. So when they act on the acini cells, it will cause them, it will ginger them to extract from the maternal blood. The maternal blood, it will help it to extract breast milk, more nutrients. It will help them to extract more nutrients from the maternal blood to manufacture the milk. Okay, so now if you look at the physiology, then the physiology of the production of milk will end at this stage, where the acidic cell extracts nutrients, essential substances from the maternal blood to produce the milk. Now, when this happening, after they have manufactured the milk, they'll push the milk into the lactiferous tubules. Then the physiology is okay. It has ended for the passage of the milk. Remember, the milk cannot stay there. The milk will have to flow so that the baby will now get the milk. And that is where we will start with the passage of the milk. Now, if you look at the passage of the milk, the moment it gets here, then oxytocin will be released from the posterior pituitary gland. And we all know the function of oxytocin. I think I have talked about it. Then when it is released, what do you think will happen? The moment the oxytocin is released, they will cause contraction of the myoepithelial cells. Normally, we call them the basket or spider cells. Then they will cause it to contract. Now, when it contracts, it will help it to release the milk. Okay, so milk will be released from the lactiferous tubules to the duct to the ampulla, and that is where areola. The baby should always suck the areola, but not the nipple, because that is where the milk is stored. If the baby suck, then the milk will now flow. Now, if we look at the physiology, what is our responsibility as midwives? Now, let me quickly show you an image, and then I'll go. Okay. There we have two stages. The stage one is the production of milk. So the moment you deliver or the placenta is delivered or expelled, then placenta is no more to produce estrogen and progesterone. So its level will go down, and that will enable the anterior pituitary gland to release prolactin. Now, the prolactin will be released into the maternal blood. And where are they going? Straight to the mother's breast. They are going to the breast. So this is the mother's breast, anatomy of the breast. Now, when they get into the breast, what is their responsibility? They said when they get into the breast, if we look at this place, we call something the prolactin make them to secrete milk. It will come and act on the acidic cells, milk cells. So it will act on the acidic cells. And what is the responsibility of these cells? Their responsibility is that now, because there is an increase in blood supply around the breast, it will enable them to extract nutrients, essential substances that is needed for the production of milk. Okay, so we know the substance, there are many. Composition of the breast milk. So now when they produce like this, then they are done. Okay, they are done. Production has taken place. Now, the breast will not, milk will not stay in the lactiferous. It will not stay in the lactiferous duct. It will have to flow. So the process is over. Now, it is left for the mother or the midwife to put the baby to breast, or by nature, oxytocin will be released from the posterior pituitary gland. Or even if you give oxytocin, you even help with the process. So now oxytocin is released, and oxytocin released from the PP will now go straight to go and help with the myoepithelial cells, where I'm pointing the cursor. It will act on the myoepithelial cells here. And so these are the cells. So when it acts on the myoepithelial cells, which is known as the basket cells of the breast, they help to prepare the milk from the alveoli. So we all know the alveoli. This is the alveoli. We have so many of them here. So now milk will now flow from the alveoli towards the ampulla. So here, this is the ampulla. Another name is the lactiferous sinuses. So here, the milk will be stored here. So here, now, if the mother puts the baby to breast, and the mother put the baby to breast on the nipple, you find out that this lactiferous sinuses or the ampulla, the baby's mouth doesn't get here to squeeze it for the milk to flow into the baby's mouth. So the baby will end up just pulling the tissue around the nipple, and that will result in the sore nipple. Okay, so we always tell the mother, if you find out that this dark portion, the areola, you see the dark portion, this is where I'm pointing the cursor. So we always tell the mother to put the baby to breast with the areola, that is the dark portion. So if you look at it, if the baby mouth gets here and the baby suck the areola, it will squeeze the lactiferous sinuses or the ampulla. It will squeeze them for the milk to flow through the nipple onto the baby's mouth. So that is why we always tell the mother that, oh, please put the baby to breast around the areola. Okay. Now, let's look at I was always talking about midwife responsibility. Sometimes you go to the postnatal clinic and you will see a midwife seriously educating the mother that the mother should eat well for the breast milk to flow. I don't know whether you were a victim. If you were a victim today, you know. Oh, mother, eat well. Eat. Mash kenke. Mash with granules. Bring soup. Bring soup so that the milk will produce more and then you'll be fine. No. If you look at the physiology, if you understand what I'm saying, the mother will have to eat well so that the acne cells will be able to extract from the maternal blood the essential nutrient, protein, fat, and whatever, rich nutrients to manufacture rich breast milk. So I always tell my students that if you look at the baby, you'll be able to tell what is wrong with the mother because it is what the baby is taking. That is what is coming from the mother's system. So if you find out that the baby is marasmus, which they normally say asram, there is no asram anywhere. There's nothing like asram. If the baby becomes marasmus, it means this mother is not eating well for the acne cells to extract nutrients, good essential nutrients, rich nutrients, vitamin, minerals, everything is there to manufacture the breast milk. So what my mother is eating is what the baby is eating. That is why sometimes when we get clients who are going through depression because the husband is neglecting them, they will tell them, he has divorced me. You have break up with me. I won't take care of you. Remember what the mother is eating is what the baby is also eating. So we encourage the mother to eat a nutritious diet so that the acne cells will be able to extract rich nutrients to manufacture the breast milk. But we don't encourage mother to be eating because we want production. If we eat too much, it doesn't make the breast milk flow like they are saying. But it will tell the mother that, oh, I'm having a good nutrient. So the breast milk that the acne cells are going to extract to produce the milk will be very rich and it contains the nutrient that the mother is eating. And the baby will be able to grow well. However, we encourage the mother to put the baby to breast frequently. Okay? The more you put the baby to breast, the more the baby suck the areola, and then this place will be empty. So the moment this place is empty, the more the myoepithelial cells will squeeze it for it to flow, to come and flow for the next one. Then it will be going this way, going. So you remember that as more is being produced and baby is taken in, then the prolactin is also working to suppress the ovaries. And it will serve as a good family planning method, lactational amenorrhea for the mother. At the same time, as the process is ongoing, it will also help the oxytocin to be released more. It will benefit the breast at the same time, help with the involution of the uterus. So we encourage them to eat well so that the baby can get a good nutrient, and the baby doesn't become marasmus, like people say, kwashiorkor or asenam, okay, which is, there is nothing like that. So please encourage your client to eat a nutritious diet so that the baby will get a good nutrient. Then encourage the mother to put the baby to breast frequently so that the milk will not stay there for a very long time. And we all know that if the milk stays there for a very long time, they can be pushed into the tissue of the breast, and that may result in more conditions or problem like the breast abscess or mastitis. So now that we understand the physiology, then we should know what to do next for the mother. Okay, so there is nothing like asthma, please. It's when the mother is not eating well and the baby is not getting. I don't want a midwife to be saying that there is asthma. It says when the mother is not eating well and the baby is becoming marasmus. Okay, so we have pain can inhibit the production of milk. Remember, now we understand the physiology. Okay, I was asking what is the role. So anytime if you look at the physiology, it's all about brain, hypothalamus, under it we have the pituitary gland, anterior, posterior, they are all working. So psychologically, it's about the brain, which is functioning. So anytime the mother is in pain, okay, anytime that the mother is in pain, anytime the mother go through the pain, anything that can trigger pain, then the physiology will be altered. And because it's straight from the brain, then it will be replaced. The pain releases some hormone to cease the physiology of lactation. So if the client is in pain, it inhibits breastfeeding. And I like this question in the exams. Okay, so because everything is about the brain, anytime the mother is in pain, when we talk about pain, after pain, anytime like a bad news, the mother is going through stress in the house, so many things after delivery, those that are even discussed, the stages, it can inhibit the production of breast milk and it will just cease. That is why you need to counsel them. It's about the mind. And then sometimes the clients will tell you, I'm not getting breast milk. I'm not getting breast milk. It's about the mind. You are busy thinking of your husband who is not giving you money. You are busy thinking of your husband cheating on you. You are busy thinking of what to eat. And it has taken over the physiology. So if you let them understand it's about the mind, everything is from there. Now, I like, because of time, that if there is maybe somebody picks some, you lost the mother, and then maybe the grandmother or anybody taking care of the baby, and then the person starts to give the baby her breast, what do you think it will happen? You see, now you find out that when that happened, okay, when that happened, the moment the mother or the person who has adopted the baby put the baby to breast, you see, everything is about the mind or the brain. You know where the anterior pituitary gland, just at the base of the hypothalamus. So the moment the person puts it there, you find out that a message will be sent, and then the physiology will just start. Though there is no placenta, there is nothing. You see, God is so lovely. The physiology will start because the person has tuned her mind that I'm giving this breast to my baby to enable me breastfeed this baby who has lost the mother. So the love is so strong that the physiology will start by its own. At the same time, when somebody gives the breast to the partner or the husband, now we said that, oh, when you give your breast to your partner, it prevents breast cancer. Please, it's not true. Now, I don't know whether I will be teaching you guys when you get to breast cancer. Normally, the physiology, the hormonal aspect, the baby sucking, and then the breast tissues resting within that period after delivery are those processes that stop breast cancer. So if you give your breast to your partner to suck, those physiologies are not taking place. Okay, because what is your reason? Now, anytime your partner suck your breast, Your reason is that you are giving your breast to your partner to show something like arousal for sexual intercourse. So that message will be sent to the brain. And then the brain, oh, I want to have sex. So the moment I want the feeling, then you will become wet for your partner to penetrate. So that is the only thing you are saying, telling your brain, but not the flow of breast milk. So please, that one, it doesn't, but you get some midwife saying, oh, when your baby suck your husband suck your breast, it will protect you from breast cancer. So now that you will not say it again. Now we have, today I have to move a little bit faster because I don't know. So we have changes in the bladder. And I think I talk about it, that within the first 48 hours, there will be increase in urine output. I think I've talked about it. Then the cervix will regain its hard within 2 to 3 days after delivery. You'll find out that the internal ops will close as before, but the external ops doesn't close completely. And that is what we said. If you do V, you'll find a tip of finger can be inserted into the cervix. And that is what we call the multiparous ops. And here we have a role. Sometimes it is very difficult to differentiate multiparous ops from 2 cm dilation. When a multiparous woman comes in labor, oh, the cervix is 2 cm. Find out, sometimes it may be a multiparous ops. If you look at the texture of it, how loose it is from the baby's head. And remember, in a multiparous woman, we said there will be no effacement. And we said the moment, I remember somebody asked me this question, how do we differentiate? One, in the multiparous woman, there will be no effacement. In a multiparous woman, there will be no effacement of the cervix because in the gravida, somebody who has not delivered before, from 36 weeks, the room or the space for the baby to move is limited. So in the gravida, from 36 weeks, the fetus will have to descend into the pelvis so that the fetus will get room to rotate. Now, in the multiparous woman, the person has delivered before, so the abdomen or the uterus is lax. So there is more room for the uterus, for the fetus to rotate. And so because the uterine muscles are lax, there are more space. Therefore, there will be only effacement. That is the taking up of the cervix when the client is in labor. So you find out that if the client is in true stages of labor, when you do the VE, the cervix will not be loose and hanging, but you find out that the cervix will be in phase. Okay, the cervix will be in phase. So that is why we say effacement will only take place in the multiparous woman. So you should be able to differentiate between the multiparous ops in the multigravida clients. Okay, then, so this is what I'm talking about. When we have the changes in the vagina, we said after delivery, the amount of blood supply to the vagina is reduced, giving it back its pink color. But we said the hymen is not completely broken. When you have sex, you break your hymen. But after delivery, when the fetus passes through the vagina, it causes the hymen to be completely torn. And that is why we said it will heal and leave irregular tissue. And that is what we normally call those who sing the vagina song. It's normally leave the caniculum multiformis. That is what we see. Then we have changes in the pelvis or the perineum. We said by the 3rd or the 4th day of the period, most of the muscle tone of the perineum has been regained. However, if the client was given episiotomy, you have to inspect and see how the episiotomy is healing. Or if the client had a tear and you have to suture, you have to counsel the client to take good care of the vulva hygiene, so that the episiotomy or the tear that become infected, okay, and that is very, very important. Then the ovaries, they resume their normal function. But you remember I said here, it depends on breastfeeding, okay? If we breastfeed the baby frequently, you understand the physiology of lactation. Prolactin will be released to suppress breastfeeding. And that's very much. Reading assignment is on. Reading assignment is on. Okay, so I think it's time